A warm welcome to everyone. I am Dr. Gaurav Singh. Today I will be presenting an unusual presentation of influenza A H1N1 myocarditis, a case report. I would like to thank my professors Dr. P.K. Prashar, Dr. Udit Narang, and Dr. H.K. Rao for helping me throughout this. As we all know that influenza is an acute respiratory illness caused mainly by influenza A or influenza B viruses, which can occur in outbreaks and epidemics. The signs and symptoms of URTI and LRTI are present, along with indications of some systemic illnesses such as fever, headache, myalgia, and weakness. Though it is a self-limited infection, it can produce some grave complications, included like myocarditis, ARDS in certain individuals. Acute myocarditis is a well-known cardiac complication of influenza, and it varies from asymptomatic infection to fulminant myocarditis, which can also result in severe hemodynamic dysfunction, which might require inotropic support or IABPs. Today, we are reporting an unusual case of influenza A H1N1 viral infection, which only presented with fever and syncope. The patient was an elderly female with hypertension and diabetes as comorbidities. Case summary. A 73-year-old female, known case of hypertension and diabetes since 10 years, came with chief complaints of fever and blackouts since last one day. Blackouts lasted for 2 to 3 seconds with frequency of 3 to 4 episodes per day since one day. It was also associated with body ache and generalized body weakness. There was no chest pain, palpitation, cough, breathlessness, or history of swelling of feet. No history of seizure, weakness in any part of the body. She was not a known case of coronary artery disease, tuberculosis, or COPD. There was no known allergies. There was history of contact with person coming from outside India. The treatment history consisted of furosemide, which she was taking for hypertension, and metformin, rosuvastatin, ecosprin that she was taking for diabetes. On general examination, patient was conscious, alert, but febrile. There was no cyanosis or icterus. The vitals were pulse 64 per minute, PP 140 by 80, respiratory rate was 24, saturation on room air was 94%, and with 100% with 2 liters per minute oxygen via face mask. The RBS was 124 mg per deciliter. On respiratory examination, there was equal bilateral air entry with minimal bilateral V's. Neurological examination was well within normal limit. There was no neurological deficit at all. Cardiological examination was also normal. S1, S2 was normal. No murmur was present. JVP was under normal range. Per abdominal examination was also not significant. Initial blood examination suggestive of mild anemia, but subsequent CBC showed lymphocytosis with low normal TLC, which is an indicator of viral infection. Her liver and renal function tests were well within normal limits, with serum sodium on the lower borderline side. Her RBS was little raised. One notable finding was her elevated CPK, that is creatine phosphokinase, which raised suspicion of muscle injury or muscle inflammation. Now you can see the investigations of my patient on daily basis. On the first day, the TLC was 4,720, which actually started to decline. On the first day, the lymphocytes were also less. It was 16, but it started to rise. Like next day, it was 48%. The other day, it was 46, and on the 30th of March, it was 71%, which is clearly an indicator of viral infection. This is a renal function test and the liver function test. On the first day, there was low sodium, but from second day onwards, the sodium became normal. You can see the CPK value is quite high. It is 206. The patient was taking rosuvastatin, that's why the lipid profiles are also on the lower side. That is not significant for us. Now, coming on to the chest X-ray, it shows mild peribronchial coughing in the bilateral regions. You can clearly see these are the cuppings. These cuffings are caused by peribronchial edema, and because of that we can see some circular bronchial markings on the chest X-rays. Her ECG showed sinus bradycardia. On the cardiac monitor also we saw the heart rate to go as low as 38 beats per minute at night while sleeping. So in view of elevated CPK and the sinus bradycardia, we ran NT-proBNP and HS-troponin test, both of which came very high. You can see the HS-troponin I, which is a cardio-selective troponin I. It came 2473 and the normal range is just up to 15.6. At an NT-proBNP of value 1810, which is also very high, and the normal range of NT-proBNP is 900. So this led to the suspicion of myocardial damage and inflammation, for which we did a 2D echo. Though the 2D echo came normal, the ejection fraction was just 60% with no regional abnormality at risk. There was just trivial TR found with no significant pulmonary hypertension. No clots of pericardial effusion was seen. At this point of time, we were suspecting viral myocarditis because she is having the symptoms of fever with high lymphocyte percentages and this much like elevation in the HS-troponin and NT-proBNP. So the patient's nasopharyngeal swab was sent for H1N1 RT-PCR, which came out to be positive. The patient was immediately shifted to the isolation room of the medicine ICU, and oseltamivir, that is Tamiflu, was started at 150 mg BD on the second day of the admission only. Her vitals remained stable at all time with minimal requirement of oxygen support via face mask or just nasal cannula. Her subsequent HS-troponin values initially showed a rising trend, but later it showed a declining trend, which was a good prognostic sign. There is one more thing that I would like to tell you, that usually the viral myocarditis picture is something like low cardiac output with dilated cardiomyopathy. In this condition, it was not seen like this. So it also shows a good prognostic sign. Later on, her bradycardia also got resolved, though she had brief episodes of ventricular trigemination, which later also got resolved. There were no electrolyte imbalance. Her chest X-ray also improved. You can see now there is no cupping. The haziness is slightly less also. And after 5 days of the treatment with oseltamivir, all her symptoms got resolved and she was discharged with vital stables. So, in the end, I would like to tell you that physicians usually attribute blackouts to the neurological causes, such as transient ischemic attack, epilepsy, etc. And many of them are right as well. The other common causes could be orthostatic hypotension, dehydration, but they less often think about having cardiac pathology when the patient presents with blackouts, and we usually don't do a thorough cardiac examination. And if there is fever accompanying bradycardia, one should suspect having a viral myocarditis as a cause and should investigate. Though tachycardia is the most common finding in cases of myocarditis, this case presented with bradycardia and hence syncope. Patient didn't have classical symptoms of flu like cough, coryza, cold. She only got fever, which was followed by the blackouts. Some simple investigations such as CBC, ECG, CPKMB, TROPI are of great value in making differentials and coming towards the diagnosis. And after screening and appropriate evaluation, one should go for complex investigations such as 2D echo or RT-PCR or coronary angiography. Though this patient didn't develop severe hemodynamic instability, one should always be vigilant of dreaded complications such as fulminant myocarditis that one may develop anytime, which might require inotropic support and IAPP, that is mechanical circulatory support. We stress the need for increased awareness of influenza-associated myocarditis, though caused by any kind of influenza virus. Such knowledge will facilitate early diagnosis and treatment of this fatal complication during future influenza pandemics. Thank you, everyone.